5, 4.
Good afternoon everyone, and welcome to Chronic Pain Australia's National Pain Week Facebook Live event. My name is Caroline West. I am a GP who has a special interest in chronic pain. Now during the next hour we're going to be discussing how pain is managed in Australia and what people in pain have told us they need from their healthcare professionals. Now if you're a regular user of the Chronic Pain Australia Facebook group, then you'd also have seen recently that we asked you for your questions, and today, in today's discussion, we'll endeavour to answer as many of those as possible. Joining me today on the panel are a bunch of fellow health professionals who have a really strong interest in chronic pain. First of all, we have Dr. Coralie Wales, who's actually the National President of Chronic Pain Australia. Then we have the National President of the Pharmaceuticals Society of Australia, Dr. Shane Jackson. Thanks for coming up all the way from Tasmania. Is that right?
That's correct.
And the President of the Australian Pain Society and Chronic Pain Australia board member, Fiona Hodson. Thank you for joining us and welcome everyone. So Coralie, first question to you. We've had the survey that's come out this week for National Pain Week. What are some of the key messages that have come through loud and clear?
First of all, Caroline, thank you for being here and for chairing this tonight. I have to disclaim though, I am actually representing the millions of people that live with chronic pain on this panel, more so than a health professional interest, because chronic pain has heard the voices for so many years. My function here on this panel will be to really voice what we've heard. And I guess, interestingly, with the survey that's just come in, the results have really indicated that many things haven't changed for people in pain. They overwhelmingly, across all of the questions, they were telling us that they still feel quite stigmatised by living with the condition, that they are concerned that when they go to their GP, when they go to their pharmacist, their allied health professional, they would really like a bit more understanding, a bit more depth of relationship, if you like. An understanding and empathic relationship to help them with their pain. Another big picture theme that came across was that people in pain are really struggling with access to helpful, productive therapeutic options. There is also a theme of impoverishment, that people can't afford some of those options that may give them a solid management plan for their chronic pain condition. I guess there were themes. We did ask the question, did people in pain feel that the federal government was doing enough to support them in managing their chronic pain? And 98%, nearly 99% felt that the government wasn't doing enough to support people that were living with chronic pain. Financial access, easier access, medicinal cannabis was a massive theme. Give me access to something that may not carry with it all of the side effects that some of the other options have. So medicinal cannabis came across, in most of those questions. People were saying, please, we know that there is evidence that says that it may not work for everybody, but it may work for me. And certainly anecdotally, we've heard that it does work for some people. I think that really covers off the big picture of what we found. Caroline?
Yes, and hopefully throughout the next hour we'll be able to go back to that survey and really draw upon that pool of responses that you had from 1,200 or so
more
participants.
Than 1,200,
Great. Now, over to you, Shane, as a pharmacist. You've had a look at the National Pain Survey. What do you think were the key messages that came through from your perspective?
There's a few things that came through. I'll probably focus from the pharmacist perspective, I think. The first thing that came through to me was privacy. There was an absolute desire for more privacy within the pharmacy setting, and I think that that's something that community pharmacy needs to focus on. Our organisation's estimates are that there's somewhere around 50 to 60% of community pharmacies now that actually have a private consulting room. So that's good. Probably up from about 5 or 6 years ago was probably half that. So I think with vaccinations being offered in pharmacy and other sort of sit-down type services, that they are more available. So having so the first thing is that these community pharmacists and the pharmacy owners really need to make sure that that's an option. If they don't have consulting rooms, they need to really look at seriously putting them in. Second thing is that if you've got a consulting room, you need to use it, and so still focusing around the privacy issue. It's not just the consulting rooms. It was around don't have a conversation with me about my pain that other people can hear. So and I think it's just about being having empathy, understanding that these are sensitive discussions, whether it be about pain or whether it be about other things, that really need to be done in a sensitive way. So the privacy for me was really actually an overwhelming one. And maybe it's one that I'm pretty sensitised to. My pharmacies, I've got 2 pharmacies that I have in Tasmania. One of those pharmacies has got 3 consulting rooms. So, we're very focused on making sure that we've got the opportunity to have private discussions, should those private discussions be desired, and I think that that's really important. Sometimes people actually might feel uncomfortable about going into a private consulting room in the pharmacy, and that's fine, but having the opportunity for that to be offered is really important. So that's the first thing around the privacy. The second area was, I think it's really around tailored discussions, and so for me, so I think in the report it was, don't ask me 50 million questions, and I think that comes to making sure that the interaction that you have with a person who has chronic pain is really tailored to them. So it's not the and I know from a patient's point of view, sometimes the questions that can be asked in pharmacy can seem that they're not tailored, and that is unfortunate if that's the case. But what we should be trying to focus on from a pharmacist's perspective here is not have you had this medicine before, but how is this medicine working for you? How is your pain? So it's really flipping it around, and certainly in all the education sessions that I've done for pharmacists or pharmacy assistants, we've always tried to flip it around. It's not a yes or no answered, not a closed question that you're trying to ask. It's really trying to unmask whether there's what I call unmet need. And that as a pharmacist and any healthcare professional, that's what you're trying to do. So for me, they're probably 2, and we can talk about some other things later on, but they're the 2 things that came out for me: the privacy and making sure that the questions really do resonate, or actually are there trying to focus on the needs of that individual.
Yeah. And Fiona, from your perspective, what was the feedback for health professionals? What do all of us who work as GPs, nurse practitioners, people working in hospitals need to be taking on board?
I think it was encouraging to see that over 67% of people actually were referred to other allied health, what we call other health professionals in the community. I'm assuming it might be the community, for their pain management. So they were seeing a diverse range of people, such as physiotherapists, occupational therapists, dietitians and pain specialists. And 42% of those people were actually seeing a combination of those people. So from an evidence base, that was a good thing. One of the biggest things that came up was that actually people found accessing them was okay, but the affordability, 87% of people said that it was really unaffordable for them to access lots of those. And as Coralie had mentioned before, when you're in pain and you can't work and you're impoverished, how can you afford to do that? The other take-home message for me as a health professional is that people like to be and need and want to be listened to. They don't want to feel rushed. They want to actually, tell their story and talk about their experience because it's unique to them. And so I think as a health professional, and why I sit on 2 boards, one being a clinician and the other one with the Chronic Pain Australia, is because I think it makes me a better clinician, because I'm actually, listening to what people experiencing pain are actually after. Mm-hmm. So they were probably the key ones that came out for me.
And I guess it was interesting that the survey is really looking at the perspective of the consumer in this instance, and really listening, asking for feedback from people who are actually living with chronic pain in the community, or people caring for others living with chronic pain. And the final results of this survey, of course, the National Pain Survey, are available on the National Pain Week website, which is www.nationalpainweek.org. cbdopioids.org.au. So if you'd like to see more details and certainly a breakdown of those 30 questions, all of that information is there for you. But let's move on to you, our Facebook friends, our Facebook group, and some of the questions that have come through, which are really very interesting in terms of the sorts of things that they cover. So the first question comes from Angelique Rosewood, and she says, I have had complex regional pain syndrome, or CRPS, for 10 years. I've exhausted all current treatments and therapies. How does the panel imagine a multidisciplinary team approach would be beneficial to me when I'm unable to work, unable to leave the house with a carer or support person? Who feels as though they're in a position to answer that? Coralie?
Well, I mean, you go first, Fiona, because
Fiona?
you're a clinician.
Well, I was going to say that obviously one size doesn't fit all, so everyone's experience is different. So when we talk about a multidisciplinary approach, we're talking about using like a psychologist and a physiotherapist and a medical person or nurse or what have you to help that person to set their own goals, to work through that and help manage their pain themselves. 10 years is a long time, and you know it's hard to actually say, because the evidence might say one thing and one treatment might work for one person and it might not necessarily work for the other person. But generally speaking, working as a team and as a health professional working in the tertiary hospital sector, we try and work very much so with our general practitioners, because we feel that the patient, that's they're their manager, so they're the ones that are coordinating their care. So it's hard. It's a hard one, because, as I said, sometimes it may not ever, you know, we're not ever necessarily going to find a cure, but if we can help the person manage it better, then hopefully that will enhance their experience of their pain.
I think there's a couple of things to say about CRPS. Over the years, we've been contacted by a lot of people that are living with this just awful, painful condition. And for many people, pain clinics don't work. For many people, you know, a lot of complex interventions don't necessarily work. Even mirror box therapy is often recommended for people that have complex regional pain syndrome.
Can you just describe what that is?
So mirror box therapy is where you are using processes in the brain to, if you like, trick the brain into an experience, which is that it's often limb-based. It's often about a bad arm or a bad leg or a bad hand or foot. That this arm, which is bad, you know, not a good arm, is actually hidden, while the good arm is reflected in a mirror, and you're looking at the mirror and seeing what appears to be the bad arm actually moving without pain. So it's a way of kind of engaging the brain, if you like. And I've met people for whom that hasn't worked, and yet there is some evidence, and promising evidence, that will work. I guess that's the first point, that it's such a horrible condition, and it's tricky and it's unpredictable, and people can have, you know, the pain jump from one limb to another, and it's excruciating. People really do become quite disabled with this. It's been called the worst pain condition ever. So, but the second point is that getting to 10 years, often it's an innocuous injury that causes complex regional pain syndrome. It's something, you know, I remember a young fellow who was only 20, and he was a slight build, and he was a motor mechanic apprentice, and he was being bullied at work, and he was pushed to do a particular task, which he said, I'm not up for this. But they said, you have to do it. And there was a lot of people bullying him into doing it. Now, he had a little fall. It wasn't a big one, but he hurt his knee. And he went on to have the most dreadful pain condition. And when I met him, he had, you know, a tiny, tiny little leg, which was the painful leg. It had withered, and he couldn't walk. He just couldn't walk. And nothing was working for him. Now, you know, so I will say that it's bigger than just an injury. It's often about really stressful conditions that people have to work under. And the worse the conditions that the person is in when the injury happens, the more likely you will go into these complex pain states. So I think it's bigger than just the pain team. I think it's what do we do, you know, how do we look after each other before the injury even happens. So that's a bit of an upstream way of thinking about it, but it's bigger than Ben-Hur. What sort of a society are we? Do we do a lot of bullying, and does this cause things that we don't predict? I know that that's a bit of a rant, and I apologise for it, but I really feel for people that have this condition. It's just an awful thing.
I mean, in terms of sort of the team approach, one of the things is to really also use your GP as your central advocate, because even if they don't know the answers, they can often help you put a framework in place to help you access services. So in my practice, for example, we work closely with Allied Health, who are part of our practice, and also the nursing team, and very often they will help our patients plug into services, be it aqua aerobics, be it local movement groups, be it other things which can be accessed for very low or free cost.
I think the other thing, Caroline, is the relationship. You know, if you're suffering with a really horrible pain condition, but you know that people around you actually care and believe you, it goes a long way to making your life livable.
So that may be another thing, to actually find a GP who's empathetic and who gets your situation, who can help you coordinate local teams. Of course, people in rural and remote areas often have a hard time with that. But what's available in terms of internet support for support groups and to at least connect with other people?
I work in Newcastle, and we do offer some telehealth services to rural and remote communities, and also our service will help connect with local allied health people and support them to support the people in the community. Most pain clinics these days will have a telehealth option, and most GPs now are also happy to have that, and the practice nurse who might also support the person can be involved in their care coordination and that as well.
Okay, well that's good to know.
And it's funded. There's some billing arrangements that can also help them as well.
Okay, great. Well, we've got quite a few questions, so let's roll on to the next one. Our next question is a long one, but demonstrates, I think, very, very well what a lot of people are feeling who are living with chronic pain. And the question comes from Amalia Nash. Why do so many doctors lean towards shaming their patients rather than listening? Why, if opioids don't work for chronic pain, is there not a substitute that does? I do everything I am taught to manage my pain long term, like see an exercise physio, psychologist, pain specialist. I apply meditation techniques, use essential oils. I will try anything. But what happens when our pain spikes? What do we do? Last month I was sent home from 3 hospitals because they couldn't help my spike. They had exhausted their capacity as an emergency department, and even in wards. I don't have any ill feelings towards them. I just want to know why they can't help me. Why is it that when you're doing everything you're taught, when you experience a spike in pain, which is a reality for people living with chronic pain, then you are most misunderstood and told that no one can help you? The most alone I've ever felt has stemmed from the medical industry's lack of understanding. When will things change?
Yes.
Great question, and I think it really does encapsulate what a lot of people are thinking and feeling at the moment. So I think it's a really good question. I'll go back to the idea of empathy and how important it is for clinicians to take a lesson out of this kind of data, that people in pain really do need a caring human relationship with whoever surrounds them, whether it's the pharmacy people, whether it's the allied health people, whether it's the GP. People, we're all people, and we need to have a relationship with each other. I mean, I would also say that an emergency department is probably the worst place for somebody who lives with chronic pain. An emergency department is not well kitted out to help somebody with chronic pain. I think a GP that cares is a better place for you to go if you're living with chronic pain. Having said that, if you live in rural Australia, you may not have easy access to a GP.
But you've probably not got easy access to an ED either, an emergency department.
No, it's true. It's true. Yeah, it's a woeful situation for people in pain.
Yeah, it really adds to the stigma that people are feeling around that. And as in our practice, we obviously say people that they manage their flare-ups and so forth. So which is the spike I think this person's referring to.
I mean, I guess the thing is, it's all about pacing and sort of understanding the patterns of your pain, and that there will be good days and bad days, and planning also for options about when it's going to spike and what you're going to do to manage it. So often I see people who present to me for often the first time with chronic pain, and they're a new patient and they say, look, I've been to the ED and then I had all these scans done and whatever, and they're very frustrated that then they get booted out. And not really well managed. But I guess the ideal management is to sort of put a system in place where you don't end up in the ED because, as you say, the ED is a busy, congested place where you're not even going to get somebody who's probably going to have the time to take a good history and understand your story. So I guess it's also about sort of finding a good clinical team to come up with some sort of framework that plans for those days when you have a terrible time.
And I think the other question was around the medical, whether it's medical or other health professionals, is around getting them to better educated around people experiencing pain, and you know that they'll have these issues, to be a bit more empathetic towards their issues.
We also have to advocate that if we want empathy, if we want empathic health professionals, then we have to include people in pain in their training, because it's not until you have a close relationship with the person that lives with pain where you really see you walk a mile in their shoes, and in a training setting you've got opportunities for health professionals to actually be much more aware of the lived experience of people in pain. So this last question, the most alone I've ever felt has stemmed from the medical industry's lack of understanding. When will things change? They will change when there's a better partnership relationship between people in pain and training programs. You know, we've got to be inclusive. Nothing about me without me.
But I think from a positive point of view, in terms of when will things change, that you're asking is really that things are changing, that there's a feeling, you know, that it's very much us and them, but I think that that's actually shifted enormously. And I think this whole idea of the person being the central player in the team is a concept that's pretty well established now in training modules with GPs and at an undergraduate level. That certainly wasn't the case 20 years ago. So I think that is already changing, and I think the fact we're no longer silos, we do have a team-based approach to people living with a chronic condition.
So is it about finding the right team?
I think so, and the thing is that I don't think that there's enough funding in place to ensure that every team member is going to be accessible at all times. Yeah. But I think that there is already change, and that's on the way. Like I think that the future looks a lot brighter. It's very easy to look at the future and think, oh, it's all doom and gloom. But I think that the language around it, the acceptance, the profile, is shifting. Do you feel the same?
Well, look, I mean, I guess what we do is we listen to what's going on out there, and so you know, and I find I know that there are some shifts. I mean, there's some great resources out there that I know of that are available. Whether or not everybody has access to those resources is a question. I mean, Mary Lynn, who is one of our ambassadors, lives with chronic pain, and she was able to access a multidisciplinary team, and she's been with that team for 4 years now, and that's really worked for her. She's come from probably where Amelia is to being able to climb the Harbour Bridge in 3 or 4 years. It's been very small steps, but she did access that team, and it was the right team for her. Not all teams are going to be right for every person, and so even though it's hard, I mean, I would encourage people to keep looking. If you've got a GP that's not like you, or a pharmacist that's not like Shane, or a pain clinic that's not like the one that Fiona is in, then maybe you're in the wrong place, and maybe it's a question of not giving up and knowing that there are good people around who do care. You know, and you get exhausted, and you know, you run out of steam basically. But I would encourage people to just not give up. You know, there are great people out there.
I'd agree with that. I think it's worth, where there are options, trying to investigate what the right team is. Yeah. And also, just back to Amelia, you know, as much as you can, planning ahead for those flares, because the last place you want to be, as you said before, that person with chronic pain ending up in the acute emergency department. It just doesn't.
Well, they don't manage any chronic disease as well,
no,
and a lot of people end up there because they lack the money or the time to go in other hours, and it's the most sort of it's an easy way to access care and sort of interventions for some people, but it's absolutely hopeless at managing chronic disease because they don't even have a bed to put you in. They don't have trained staff to manage you, and you're going to be discharged into the community.
And I think the other thing is with regards to that team, find a health professional that gets you in your pain. Right. It may not be the GP sometimes. It may be the pharmacist or the...
But the pharmacists are often great places to start in terms of knowing all the GPs.
Yes.
And knowing who's good.
Yeah.
Ask your pharmacist for a few tips.
Yeah.
Because you get feedback. You're like the ultimate in TripAdvisor. You know, you go, that's a 5-star GP, and I probably wouldn't go there.
I agree with that, and I think also too that lots of health professionals we're now learning and working better in what we call working in a more interdisciplinary manner, where we're looking at the person and looking at maybe their psychological distress and looking at their other issues and their diet and nutrition. And as I said, so if you find a good person, be it a pharmacist or a physio or what have you, that one person might not be able to do everything, but they can help you along the way and support you. So.
And I've had times, for example, in my pharmacies where my local GP has felt like his hands have been tied with regards to how he's able to treat patients. And I've been able to be a third party advocate in some respects in backing the GP, especially with our regulators around relaxing some of the restrictions that might have been put on what I term inappropriately. So, like I said, getting the person who gets you, and sometimes just having that team that gets you as well.
I agree.
Yeah.
I think the relationship is the really crucial part.
So, on to our next question. I hope, Amelia, that was helpful. Our next question comes from Joanne Bradley. When can we expect easy access to medicinal cannabis? Who gets asked this a lot? It's been legalised but virtually impossible to get. When will it be on the PBS? And when will the process become easier for GPs to prescribe it? As it's non-addictive and the high is removed, why can't it be bought over the counter? Why are the patient's choices being restricted with regards to this drug? So do you have thoughts on this, Shane?
Yeah, happy to start. So there's already been moves to simplify access to medicinal cannabis. Minister Hunt has talked about that, and the TGA is streamlining the process. But still, the state jurisdictions need to streamline their processes as well, because there's a number of what I might call hurdles that need to be overcome for medicinal cannabis to be accessed. The other thing is that most of the medical bodies, and certainly the society agrees with this, is that it's not generally a first line therapy. It's a therapy, at least from what the evidence tells us, where other more traditional modalities haven't worked. But that doesn't mean that we shouldn't be considering it for some people. I think what we need to do is we need to have really clear instructions is the wrong word, clear advice about this is the place in therapy, this is how your GP or specialist might access, and this is the likely time frame, because that isn't as clear as it could be, and I'm hoping that will be improved. But I think what we will see is evolution in the use of cannabis over time. I think in 4 or 5 years' time, we won't be having this discussion, because it'll be a lot more clearer around what the place, what the identified traditional place in therapy for medicinal cannabis might be. I think we'll have some clear guidance for medical professionals and also for others involved in health around this. It will evolve over time.
I think that the research is what you're alluding to, is that where it will make it probably easier. At the moment, there is a small amount of research that has been collated, and as I said, the TGA is what you're referring to, which is all around the access and the guidance document. And at the moment, as I said, 75% of people in the survey said that they would like to actually have access to medicinal cannabis and so forth. But I think it will come. But I think at the moment, from a government sort of and a clinical point of view, I think they're waiting for more evidence.
Well, the thing is, I guess that anecdotally, a lot of people report it helps their pain. We've got some patients at our practice who are already on it, and some of my fellow GPs have prescribed it. So obviously access is happening. It's a very expensive medication at this point in time, so it's simply not affordable for a lot of people. And certainly it has a clear role in things like possibly nausea with cancer treatments and resistant epilepsy in children. There's just 2 examples of perhaps a stronger evidence base. I think that when it comes to pain management, that a lot of people are seeing it as the holy grail, and sort of thinking this is going to be the answer to my chronic pain. And I think it may be one of those things that's on the suite of options, but a lot of people are hoping that that's going to sort things out. And we know that dealing with chronic pain is a very complex condition that often needs multiple things, not just one medicine.
The other thing too is that there are other places in the world where you can access affordable CBD oil. I was in Edinburgh last year, and I bought some. My son said this is CBD, and I wanted to see whether it helped me. It didn't particularly, but then I had it in my luggage and brought it home. I forgot all about it, and then my mother started talking about it. So I said, "Well, Mum, I've got a little." It was just a little tiny bottle.
And did you get it from a pharmacist in
It was
Edinburgh?
just over the counter.
Over the counter?
Over the counter. I don't even think it was a pharmacy. I think it was a health food place.
Yes.
You can just get it from a health food place, something like that. It was
And is that the bioequivalent of what's being sold in pharmacies here for hundreds and hundreds and hundreds and hundreds of dollars?
Yes.
It's
because
exactly
my
the
mother
same
went
thing.
looking for it. So I gave her this little vial, and she started using it. And she said, "My God, it's taken my pain away." And she's been trying this intervention and that intervention. Now she's 87. She's not imagining it. So, I mean, the other point about medical cannabis is, apart from it being used overseas and people reporting that it's beneficial for them, what I understand from some people in pain is that there are hundreds of cultivars of cannabis, and only a few. There hasn't been a lot of research done, which means that to actually get your head around that research and to do that research is going to be a major program. And we do have the Lambert Initiative in New South Wales at Sydney University, and I'm looking forward to that really producing some kind of knowledge base. But we have to be aware that just because the research hasn't been done doesn't mean that it doesn't work.
Oh, I think that's the case, but when you're looking at it from a political point of view, or for putting it on the PBS, at the moment we've got very few providers making it, and it costs this much money. As soon as it goes on the PBS, they're all millionaires. So there has to be, I mean, there's just a system that needs to be applied to all new medications going on the PBS. That's driven by, this is the evidence that you present, and this is going to be the benefits. I think it will be a done deal in the next few years. I don't think there's any question about it being introduced. But I still think that you need to have some process around putting stuff on PBS that needs to be.
People in pain would argue, well, why can't I just grow it in the backyard and try it for myself?
Well, that's another thing. Perhaps we should also be arguing that it should be decriminalised. And I have patients that cultivate their own pot, particularly a lot of my patients with HIV with chronic pain. In the early days, before a lot of those therapies were appropriate, and they had terrible nausea, and they reported that it sorted all of the above out. So anecdotally, there's a very strong set of feedback that comes from people living with chronic pain, where lots of other things have failed. So
certainly I have heard that too.
You hear that. I guess from a policy point of view, that that we need to also not be relying completely on anecdotal evidence to push forward health policy in all areas. So I can understand the politicians and the governing bodies going, okay, well, show me the evidence, And
it's important for those products, if they are available or subsidised on the PBS, so that product that you had from Edinburgh wouldn't have, you can't say it'd be bioequivalent to what we've got here because it doesn't have the same regulations. You don't know what the interbatch variations are, or you don't know exactly how much CBD is in that, which you will know in Australia, hence the cost of the product.
I see.
That's the difference. So it is.
So the product that you can buy at the moment from a pharmacy with the right script is actually like a medication. It's
That's
sort
exactly
of, it's
right.
quantified. This is exactly what you're taking.
That's exactly right.
And you don't get a high from it, or you don't.
No,
can you tell me a little bit about it for people that might not know?
So essentially the psychoactive component, so the THC, which is in essentially cultivated cultivated cannabis, is not in medicinal cannabis. It's just CBD. It's not the THC, which is largely the psychoactive component. So, and what we're seeing, and hopefully I think we'll see evolving, is that there'll be much more evidence established for the CBD component from a treatment point of view. Used a couple of examples there around nausea, especially resistant nausea associated with chemotherapy, epilepsy. I've got two young disabled children whose parents come into my pharmacy who use cultivated cannabis oil to treat their child's epilepsy, and the, again, anecdotal, but those N=2 reports and the emotion that he shows to me when he comes in and he tells me how effective this cultivated cannabis is, it does tell me that there's some evidence that these that cannabis can assist at some, and whether it be for pain or other things. Yeah. But I think we just see variability in response.
I think, if we were to ask for a wish, it might be to just not be so heavy-handed around people who access marijuana for treatment of their condition outside of the regulatory framework. We do come down very heavily on people, don't we?
I do think we need to understand that that's what people may feel like they need to do.
Yeah. And I think most health professionals get that, so I don't think it's coming from pushback from health professionals.
No, it's not.
It's a political
some
question.
Health professionals. I mean, certainly I hear health professionals like the Faculty of Pain Medicine and other organisations that are run by health professionals saying, well, there's no evidence, therefore we can't prescribe it, and that's a risk management framework. I get that, certainly. But I think, understanding that people are also desperate, people that are taking medicines or whatever the treatment is and they can't get a good result, they're looking for some other options. And so it's that despair and that distress that needs to be addressed.
Okay. So our next question is from Debbie Rigby, and this is for you, Shane. What role do you think pharmacists can do to better support patients with chronic persistent pain? What do you say to that?
Thanks, Debbie, for that question. I know Debbie very well. No, it's a good question because how I see this is around what I call medicines optimisation. And so we know that a number of people who have chronic pain might take multiple medicines. Sometimes those medicines might be causing side effects, they might be interacting, their pain mightn't be optimally controlled. And I see that as the pharmacist's obligation and responsibility on a reasonably frequent basis to sit down and identify, are you having any side effects from these medicines? Is it, it could be as simple as constipation. What can we do to do that? Or an itch associated with an opioid. But asking the questions around, are you having trouble? Because that may be significantly impacting on that person's quality of life. You think about medicines like pregabalin, like Lyrica, for example. They can make people very foggy. And so just asking, how's your memory? Do people tell you that you might be forgetting things? But just asking those. And just simply applying the pharmacist's expertise around medicines to help that person. So the first thing is from a side effects point of view, and the second thing is working out whether the medicine regime is ideal. Some people take opioids without taking regular paracetamol, and we know that just gives that little bit of an extra benefit. For some people, anti-inflammatories might be ideal in recommending. In other cases, that's not ideal. So it's saying, okay, can we improve where you're at with your pain, non-pharmacological methods, and just simply applying the pharmacist's expertise to that person's pain and having that discussion. That's all.
And on the horizon, there's a pain meds check, and it seems as though nobody really knows what that is.
Yes, so I thought that was quite interesting in the survey. Probably not that surprising because it hasn't actually been rolled out yet. I know Minister Hunt and others have announced that it would be, or announced in February that this was coming, and I know that there's been some delays with trial protocols and other things, but we hope it's available soon. And just to explain what that is, again, it's just I see very simplistically, it's applying that pharmacist skills as what I see a pharmacist as an expert in medicines, applying that pharmacist skills to the person or with the person who's got chronic pain and saying, is there anything better that we can do for your pain that I can, as a pharmacist, help you with? And are your medicines, in fact, worsening your pain, as we know some opioids can do, or are your medicines causing you problems that may be, in fact, causing other, medical yes, exactly, interactions and other things like that. So it's just applying that pharmacist skills in a 30 to 45 minute, what I call a consultation, which is what we need more pharmacists doing in a community pharmacy. Sitting down, having a discussion, and I'm keen to see the results of the pain meds check when the trial's rolled out, because I think it'll be quite useful.
The pain meds check will be a whole lot better when people in pain are included in the discussions on how that might look. What is the language? How do we communicate? So I'm really hoping that we can continue that conversation, Shane.
Absolutely.
And include people in pain.
Yes, yeah, absolutely. I think that's wise.
In the development.
Yes.
And I also think a key issue is the liaising with the GP, who obviously is the prescriber. So again, if the pharmacist in this meds check, I would assume that there's a letter or a referral, what have you, correspondence back to the GP, so that the person who's that the pharmacist has had the assessment with, or not the discussion with, really, that can improve things. Yeah,
makes sense.
Yeah, absolutely, and I think that's especially where there's suggestions around modifications in therapy. Then the GP is going to be the one who's generally coordinating that, and so that any referral or any correspondence should absolutely go to the GP and outlining the suggestions and outlining the rationale. And I would suggest that certainly will occur.
So it's a potential benefit that's not been there, maybe that discussion that, and then that communication back to the GP.
Yeah, it can be the backstory too. It can be what's really going on for this person that we all need to be aware of, because it might be that they need connecting into something that's not even medical, or health related. It might be something to do with the kids. What's going on with the kids? What are the stressors in this person's life? What's the big picture? What's the main thing this person would like to happen?
So our next question is from Sarah Laverick. Why is more training not provided to doctors in training on chronic pain? I've tried many doctors and specialists and generally find I have to educate them on the various pain medications and treatment options available. They are often unaware of many options or don't know what to do or what the side effects are. Multidisciplinary clinics are even worse. One prescribed a high dose of a medication that put me in emergency, many others with horrible side effects that I was not warned about. Another told me to give myself butterfly hugs and talk to me like I was 5. Appointments take years to get in, and then 6 monthly after that, hardly enough to monitor someone's treatment. I would like to ask, what will be changing in the future for multidisciplinary clinics to ensure adequate patient care, timely treatment and options besides solely medications that often don't work? Okay.
Right.
So I guess the thing is that a lot of training is not provided in undergraduate courses in a whole range of areas. You could argue that nutrition, physical activity, psychological interventions, chronic pain, management of chronic diseases is often not covered in depth in undergraduate education. And a lot of medical education requires ongoing learning. So it requires people to be interacting with ongoing learning to really keep their skills up, because even if somebody learns something in undergraduate medical school, they're going to need to top up their knowledge in terms of what changes. So I think given that chronic pain affects 1 in 5 people, that there certainly should be something that's carved out in the syllabus to really help people understand the basic framework of how it can be managed and how you can work in a team-based approach. What do you all think about?
It's really important, Sarah, that there are so many clinics around Australia and they're not all the same. And it sounds like you've had a really bad experience or a number of bad experiences with multidisciplinary clinics. As somebody who's been around people in pain and clinicians and been working in this kind of role or volunteering in this role for a long time, I know that there are some fantastic clinics. They're not necessarily in the private sector, they're in the public sector. So some of the teaching hospitals have really worked hard to build that team and to build the skills.
Are you talking about pain clinics?
Pain clinics, yeah. I'm talking about, for example, where I work, In the Nepean Blue Mountains local health district, there's a pain team there, and it is a multidisciplinary pain team. And they go out into, they go down into the country to Wagga Wagga, and they're upskilling the teams in Wagga Wagga. Now this is Nepean Blue Mountains, going all the way down to Wagga Wagga 3 or 4 times a year, and they work with the local clinicians so that that community in the country can upskill and be able to wrap around people who would normally have incredibly bad access to anything that helps. So I don't think that it's all the same colour. I think multidisciplinary teams around the country are all doing different things. And I know in New South Wales, and we've got a national audience tonight, but in New South Wales there's been a lot of energy going into those pain clinics. Now Fiona directs a pain clinic up in the Hunter Integrated Pain Service, where they avoid the waiting list by making sure that everybody gets pulled in very early into kind of an education program. Do you want to talk about that, Fiona?
Yeah, so basically everyone that's comes into an education session of about 90 minutes, where people and their support person or carers or what have you come in, and we have an understanding pain, and then people can actually ask questions to the medical staff and so forth, and also work out what is this the pain clinic for them, like is this going to meet their needs and so forth. And then if people want to progress, then they choose and then they come to the next step. So that generally works quite well, and a lot of people can discharge themselves with the resources and options that are offered to them in that program as well, back to their GP. But that's because of the demand. So we get people within 6 weeks at that first step, but not everyone's the same.
So yeah, I'd love to have your service in our area, because a lot of GPs in my area have sort of found it very difficult to interact with a lot of the local pain clinics, and so they just give up.
Yeah. And I think once you go into the private sector, then Sarah, you get those sorts of experiences like mostly medications or interventions that are quite invasive. It's a different model altogether, whereas in a teaching hospital you're going to get stuff that's much more about what do we do the least harm with. I find it interesting and sad that many people in pain actually do become the expert, and they're teaching their doctors. And if the doctor's receptive to it, the doctor does learn from the experiences of their patients in pain, their patients that are living with pain. So, I mean, again, my message to you, Sarah, would be don't give up, because they are out there. If you're living in the country, it's probably much more difficult because your options are so narrow, the further away from the major cities. But also, go to the 24/7 Chronic Pain Australia forum and ask the question, does anybody know of a good team out there or a good clinic? Have you had good experiences? I know of a few in Sydney that get rave reviews from consumers, from people in pain. So not all clinics are the same. Don't give up.
And I think there was a national pain strategy developed in 2010, and education of health professionals was on there, and recently I attended in Canberra the roundtable around that, looking at refreshing that, and one of the biggest priorities was around education for health professionals around pain management, because this issue comes up a lot. And I think we heard even back then in 2010, Coralie, that vets get 7 times more training, veterinarians in pain management than our medical
than human doctors.
Yeah.
And so, did you have any sort of brainwaves in how you could recruit doctors into ongoing learning?
Part of it is around the undergraduate programs for all health professionals, and so looking at it even as like they are in, say, overseas, such as in Canada, where they offer an interdisciplinary education approach. So for all disciplines will get the same education, but undergraduate, postgraduate, GPs, there's options, and obviously, unfortunately, some of this will require significant funding, which is again what the asking the government to fund a national pain strategy is. That's all part of it. So,
and in terms of sort of if people are finding it hard to access a team because geographically it's just impossible, what sort of online pain management programs could they be accessing that might make a bit of a difference?
So if I was living in the country right now, I would be asking my local hospital which teaching hospital they plug into, because most of those country hospitals will have a major teaching hospital. So ask the question, what's the major teaching hospital, and then make inquiries about telehealth. because, as Fiona said, many of the pain clinics now are developing telehealth models. I know in New South Wales that's the case. Is that happening all over Australia?
Yes, and it's very much so happening in obviously WA. 50% of the consultations are telehealth in pain clinics.
But they're still sort of a one-on-one sort of thing, are they? Or is
no,
there anything that people can access that sort of...
So
That's
there
their
are
own-
online resources, and if you go to the Chronic Pain Australia website, and in fact I think the Chronic Pain Australia website, there is a resources page, and we've got the top hits, and on that is the
E-Pain Clinic, which is Macquarie University.
University, and I think it's called
E-Pain Clinic.
And does that cost money?
No.
And so you can log on to the e-pain clinic and get resources and get some ideas on what to do?
And you get tutoring, you get individualised coaching.
Okay.
But that was developed, the reason it's so effective is because it was developed with consumers. So I would say, when we're talking about training, ask the question, have consumers, and when I say consumers, all you've got to do is tap Chronic Pain Australia on the shoulder, and you've got tens of thousands of people in pain who can be experts and who can be included in developing training for doctors. And the research is really clear. If you do that, you get much more empathic health professionals at the end of it. So I know that it's happening in other disease states. It doesn't happen very much in chronic pain. It's one of our calls to action. Nothing about me without me.
Yep. We're almost out of time, but I guess that we have time for one last question. This one is from Crit Kidney, who asks, why is the government seeking to eradicate opioid medication instead of using it together with a multidisciplinary approach for people living with chronic pain who have shown that it benefits them? My psych and physio only help me if I'm able to utilise pain medication as well. I've had many discussions with my pain psychologist about wanting to be able to improve my function both physically and mentally through CBT and exercise, but the refusal of access to genuinely helpful pain medication thwarts my efforts. He agrees there's no point wasting money on allied health treatments if the pain is not managed. It's a strangely vicious cycle with which most people living with chronic pain are thoroughly sick to death of.
I can start with that. So opioids, again. So I'll start by saying statistically speaking, which means that there's a bell curve, right? And that the majority of people, especially for what we term chronic non-cancer pain, the data suggests, at least the research studies suggest, that opioids aren't that beneficial in the long term, on average. Okay? That doesn't mean that we don't have some people who do significantly benefit in the long term on opioids, but on average, that's not the case. So going on from that, we do seem to have the rate of increase in opioids, which is quite dramatic, and it should turn our attention to whether those medicines are being used well across the board. Because I know in my practice, there's some times where opioids are used for too long. And we haven't asked the question, do we need to use this pain patch or any other opioid on a continual basis?
Well, I know that hospitals are trying to take that very seriously,
Yes,
because a
they
lot
should.
of initiation of opioids is actually in the hospital setting when people are admitted for an acute reason. They're put on a high dose of opiates and discharged, and 2 weeks later they're sort of then on a pattern of using opioids, and they're trying at a hospital level to reduce the number of scripts prescribed in the first place.
So I think it's probably to try and sum up there reasonably quickly, we should ask the question around opioids and whether they need to be used long term, because again the data says it's probably not ideal, but we shouldn't do it in a judgmental way. We should do it in a way that shows empathy and shows understanding of variability in an individual's response to opioids, and that we don't have a complete understanding of pain.
And look, in Crit's case, Crit is saying that when I have, and I don't know whether it's what sort of dosage we're talking about here, but if it's a low dose and it actually takes the edge off the pain and it allows Crit to do his exercise and his other therapies, but without it, he or she can't do that. I'm not sure whether crit is a girl or a boy. But if that's the case, then it's counterproductive. And so that's a really good example of how, don't demonise the medicine, it's how it's used and what is the result of the medicine. The medicine's neither good nor bad. And, I agree with your comments that, research is about a normal curve, but if there are outliers to that curve, there's always outliers, then we've got to use humanity.
I feel though that a lot of medical teams, if you have the right one though, will take that into account. Like the government's not eradicating opioids. So I think that's the first myth to dispel right there and then, that actually they're still alive and kicking. It's just that they've upscheduled the availability of them over the counter. So that's a separate issue. They're not wiping off opioids from the list.
Safety and harm reduction.
It's
and
about,
that sort of stuff.
and so I think that...
Is there not any pressure on GPs from the regulators to not prescribe?
No, there's none. It hasn't shifted as of this year. There was none in February where they started tapping on our shoulders. I mean, I think that there's been a push amongst the medical community to genuinely question whether we're using them too liberally. And I think there's been a pullback from a natural questioning in terms of harm versus benefit. And I think that the patterns overseas have been very sobering, and nobody wants to have the American experience. Not that we're anywhere close to that, I have to say, but there hasn't been a sort of a thumbscrew applied to practitioners. If they're prescribing less, it's because there's a consensus that for a lot of people they are unnecessarily on them, which has led to a pattern of long-term health complications of a consequence of overuse. So
yeah, but it's affecting crit, isn't it?
Yeah, but he could still be getting, or she could still be getting access to opiates if they're appropriate from the right practitioner. That's what I'm saying. So it's not a government thing saying you can't have them. It's more maybe it's about finding the right person who can prescribe.
What we're hearing though from the survey is that people are feeling like the stigma is there and they're being treated like drug addicts. We heard that many times.
Do you think that's changed though this year? You do?
I do. And I think the evidence is that people that can't get over-the-counter opioids, which is just a codeine, are now the higher dose Panadine Forte is being prescribed. There's more of that going out than there was before the over-the-counter prescription. I mean, I heard that from a professor of pharmacology just the other day who said that's what the evidence is saying.
Yeah, I think we just certainly have some early data to suggest that there's been a spike in the Panadine Forte prescribing, but I think we'll need to see what that looks like over time. Yeah. Certainly anecdotally, there's probably the patients that I've had who've been using over-the-counter codeine have either gone to a higher strength, they've stayed on the same strength from the GP but with a prescription, or they're actually not using it anymore. So there's a sort of a rule of thirds that I've seen certainly in my practice and when I've talked to other people. So some have gone higher, some have stayed the same, some have gone off. So yeah.
I'm interested in the data.
Yes, absolutely. Yes.
To reveal.
Yeah. I mean, I think the thing that the survey highlighted was that there were common themes that seemed to be coming through from year to year, aren't there?
Yeah, for sure.
In terms of what's changing, do you think that there are differences in this survey from previous years that are really outstanding? What do we need to be taking note of that's different to past years?
I do think so.
Okay,
I think
what are the
maybe
things,
just
apart from the cannabis and the
well, cannabis was fairly new. I think that there was more discussion about the upscheduling of codeine, and people didn't agree with that decision and felt they'd been excluded from that decision. And I think there was a lot of discussion about feeling like they were, and it's true, Caroline, they have year on year, they've talked about particularly certain doctors, certain pharmacists saying, you've got a problem here, you're addicted. A lot of people were saying there is a difference between me managing my pain and me being an addict. That nuance of language, how do we communicate? How private are we when we have those conversations? People talked about being embarrassed in front of other people when that conversation happened without privacy. So I don't know, I mean, it's 1,200 people. We don't follow those people year by year. We don't have the capacity to do that. All we can do is take a snapshot. Not sure.
In terms of how it's going to inform advocacy from the point of view of the consumer, what do you think that we're going to be looking at there? Because this is really a survey that taps into the thoughts of people like you watching on Facebook.
It's a pulse check.
It's a pulse check of how you're feeling and what are the issues that are relevant to you.
We're certainly going to be following up with each of the key stakeholders, so the allied health, clinicians, pharmacists and GPs, to say please involve people in pain as you develop materials that are going to give people better options for pain management. And that's our sort of go-to plan. I think we need to be included, people in pain need to be included, and a lot of the problems that we're seeing won't exist if that happens. That certainly happens in other disease states, but it just doesn't happen in chronic pain. So that's what we need to do, and that's certainly what Chronic Pain Australia will be doing.
Good. And do you have anything in particular, Shane, that you think you'll be moving ahead with after the results of the National Pain Survey?
I think certainly from an education point of view, it's just a salient reminder to make sure that pharmacists across settings, any health professionals are really listening, listening to the needs of the person with chronic pain. And so certainly from our society's point of view, that's what we're trying to reinforce through our education upcoming.
Yeah, and I think from a GP's perspective too, that listening is really very critical, because it's not about what I want for somebody, it's what do you want? You know, what's important to you, not what's important to your health professional, is what's important to you. You know, what would you like to see happen? What do you see the future looking like for you in an ideal world? So I think that's important to always consider it from your perspective. Fiona, do you have anything that you'd taken from the survey that you think this is really going to help inform how I work with people living with chronic pain?
Well, I think it already does, which is why 5 years still being on the board. Again, as I said, I think as a clinician, hearing what people are saying, and it brings you back to you know, check yourself as a clinician and the language that we use, the terminology, and you know, and as I said, all the things that were said there, and even when people are saying, you know, like it's, you know, if I don't look like I have my arm in a bandage, I don't have pain, and that's making sure that people feel believed and that you're listening. So again, as a clinician, and that's what I also say to when I'm educating other health professionals as well, is sort of using those examples.
Fantastic. Well, thanks to our panel, Shane Jackson, Fiona Hodson and of course Coralie Wales, and a special thanks to all of you watching at home on Facebook. Perhaps you're watching from your device or your computer. Thanks for joining us and participating with your questions for our panel. A video of this live event will be available next week on the Chronic Pain Australia website, so keep an eye out for it. My name is Dr. Caroline West, and I look forward to seeing you next time. Goodbye.